This is a very interesting topic and a very timely one. Over the past decade, working together in the Children's Oncology Group, our collaboration and others have found that there's a previously unrecognized subtype of B lineage ALL that has been called Philadelphia chromosome-like, PH-like ALL, also BCR-ABL1-like ALL. And really, these cases have a gene expression profile that's highly similar to that of the classic Philadelphia chromosome-positive ALL. It looks like there's activated kinase signaling going on in these cells, but they lack the Philadelphia chromosome and BCR-ABL fusion. And over a number of years, what's been found is that they have a very diverse variety of gene rearrangements that produce a similar phenotype that alter cytokine receptor signaling. And so, but there are a dozen involved genes, and those genes can be partnered with a diverse variety of other genes. So it's not simple to diagnose. And what we found is that there are several subclasses of PH-like ALL. I should say overall these patients have a worse outcome than other patients with ALL. And they should be, theoretically at least, susceptible to targeted therapies that are available. And so the two questions are, how do you find the cases in real time? How do you characterize them properly? And how do you show that targeted therapy improves outcome? And I think those have been the challenges. The best way to characterize them is to do RNA sequencing. So the best thing to do would be to do RNA, in my opinion, would be to do RNA sequencing on every newly diagnosed leukemia case. And I'm pretty sure we'll get there over the next 3 to 5 years, but that creates challenges today in terms of in part the cost, but also in part the bioinformatics pipelines and the ability to do that on a routine basis. So I think that's one big challenge that technology will overcome. Within the Children's Oncology Group, we've developed some complex algorithms to work around this. So over the first month, we're able to identify the cases that have different types of fusions, and we're really interested in two big classes. One have fusions that look very much like BCR-ABL, meaning they involve a kinase that is structurally related to the ABL kinase. In fact, a large number of them, it's the same ABL1 kinase, but also ABL2, the CSF1 receptor, the platelet-derived growth factor receptor beta. Because these are structurally related to ABL, they are inhibited by tyrosine kinase inhibitors that inhibit BCR-ABL. So we have developed a clinical trial, and we're testing addition of dasatinib to chemotherapy in these patients. It's too early to know whether it helps. We certainly have anecdotal reports of patients who had very poor early responses, who had imatinib or dasatinib added to them and did much better, but we don't know if it changes long-term survival. The second class is a broader class, and there are alterations that affect JAK-STAT signaling, and there's commercial JAK inhibitors such as ruxolitinib, and we are identifying cases that have these abnormalities and testing whether ruxolitinib will improve outcome. We've completed a dose-finding portion of a study where we found a dose of ruxolitinib that can be dose and schedule that we can combine with chemotherapy, and we very recently have started the efficacy part of that study to try to get a signal as to whether this improves outcome. So that's a long way of saying I think this is an important entity. It's associated with poor outcome. The diagnostics are challenging, but that will be overcome in the next few years. And then really the challenge is to see if targeted therapy improves outcome analogous to how it does in Philadelphia chromosome-positive ALL. Yeah, I think Tcell ALL, there's been a lot of improvements in Tcell ALL recently. So when I was in my training, Most people who trained 20 to 30 years ago, we learned, at least in pediatrics, that Tcell ALL did worse than B lineage ALL. That was kind of a simple fact that you were taught, and was in fact true at that time. Although in adult ALL, Tcell ALL has done as well or better than B lineage ALL for a long time. What we've seen over the past decade in our trials is the outcome of Tcell ALL has improved fairly dramatically. So just in the last 10 years, while the outcome for B lineage ALL has changed relatively minorly, about a 10% reduction in the risk of death, in Tcell ALL in our trials, we've cut the rate of death in half. So that's a pretty big change in a short time. And I think there have been other improvements in other groups worldwide. So we're seeing much better outcomes for patients for Tcell ALL than we used to. Part of that is the corticosteroid. It appears that steroid resistance is common in Tcell ALL. A number of studies have suggested that dexamethasone is a better corticosteroid than prednisone, and many groups have moved to using dexamethasone treatment as part of the backbone therapy. The other is recognizing high-risk subsets. The early T-cell precursor, or ETP, subtype of Tcell ALL was recognized now about a decade ago. When it was recognized, old studies showed that the patients had a very poor outcome, so there was a lot of interest in moving towards stem cell transplantation for those patients. Our studies show that with modern therapy, these patients do marginally worse than others, but not terribly worse, so we don't find that to be an indication for stem cell transplant in first remission. In fact, we transplant very few patients with Tcell ALL in first remission and don't find that there are clear, compelling groups that need stem cell transplantation. Yes and no. In Tcell ALL, we don't really have strong genetic risk factors. B lineage ALL, there's lots of risk, genetic alterations that are associated with a good risk or a bad risk. So finding them more rapidly is useful. In T lineage ALL, so far, we don't have that. Minimal residual disease is a good predictor of outcome. Pretty much all groups now routinely incorporate that into their risk group stratification algorithms. I think that field is moving technologically so that there are newer methods that give you better resolution of very low levels of minimal residual disease. So that may well help us identify patients who need alternative therapies. And then certainly it's quite straightforward to identify the early T-cell precursor phenotype. So you can identify that at the start, but then the question is, do you change therapy based on it? In our feeling, you don't need to change therapy based on it. Well, I think one of the things I'll speak about today in Tcell ALL, I think there's two issues. One is that every group uses some form of methotrexate intensification after remission is achieved. And in Tcell ALL, most groups have used high-dose methotrexate, so infusions of methotrexate over 24 hours followed by leucovorin rescue. We conducted a randomized trial of high-dose methotrexate versus a different schedule, Capezi methotrexate, using much lower doses of methotrexate with asparaginase. And we were frankly very surprised to see that the Capezi methotrexate led to significantly better outcomes. And this is an interesting result. I think there's a couple complications to it. One is that all the patients, or almost all the patients in our study, received cranial irradiation. Maybe in the absence of cranial irradiation, we would have found something different. And I've certainly changed my opinion over the past decade of which patients need cranial irradiation. And I think most people have worldwide. We now radiate almost no patients unless they have overt central nervous system disease. I think the other new development is the use of nelarabine, and we've conducted a study and we've shown that nelarabine significantly improves outcome in Tcell ALL, and then I think one has to figure out how to incorporate that into treatment regimens. Do we need to give it to every patient, or should we just be giving it to a subset of patients? We have elected to give it to every patient because Tcell ALL, when it relapses, is very challenging to cure. Others have advocated different approaches, and I'm not saying ours is the only way to do it, it's just what we have decided to do.